My name is Bijan. I'm from Sacramento, California, and together with President of the Society, we are moderating this section. This section is mostly focused on radiology and nuclear medicine, kind of hybrid. Our first speaker is Dr. Charles Goh. He's from Singapore, and he's going to talk to us today about imaging of the neuroendocrine tumors.
Thank you so much, Professor Bijan, for that kind introduction. And thank you so much also to the organizing committee for inviting me here to speak. I'm actually trained in both radiology and nuclear medicine. And in today's talk, I hope to give an overview into imaging of neuroendocrine tumors, and in particular to see the different roles that both anatomic as well as functional imaging play in the imaging of this disease. So as I start, maybe I'll just talk about a brief case introduction. What I feel is a fairly typical case when it comes to imaging neuroendocrine tumors. So this is a patient that came to our hospital with enlarged inferior mesenteric node on a CT abdomen and pelvis. This was done for long-standing right lower limb swelling. However, when we reviewed the CT abdomen and pelvis, there was no primary tumor that was seen. MRI prostate happened to be done in this patient as well quite recently for elevated PSA, but the MRI prostate was negative. And subsequently, because they didn't know where the primary was, a CT-guided biopsy was done, which yielded a grade 1 to 2 neuroendocrine tumor. And so this is the maximum intensity projection of a DOTA peptide PET-CT, a somatostatin receptor PET-CT that was done in this patient. And the red arrow is pointing towards the inferior mesenteric node, which was identified. However, also on the same maximum intensity projection, the primary tumor was actually revealed. So this patient had an occult rectal neuroendocrine tumor. And if you can see the MRI prostate that happened to be done around the same period of time, actually no lesion can be seen on either the T2 weighted sequence or the T1 weighted with contrast sequence. The CT similarly didn't show any lesion, but you can see the intense uptake on the PET-CT scan. And so this is how these type of tumors can often present. In today's talk, I'll be giving you an introduction to neuroendocrine tumors and talking a little bit about the anatomic imaging and where it comes in, as well as functional imaging and what role it plays. Neuroendocrine tumors are rare tumors. They have non-specific and late clinical presentation. Most of them actually do not present with any classical functioning syndromes. Almost 60 to 90% of them are non-functioning. So therefore, a lot of these tumors have a very long delay between the symptom onset and diagnosis, a mean delay of about 52 months. So it's something like 4 to 5 years between the first symptom and the time you have the diagnosis. 40 to 50% of these patients only present at the point they have distant metastasis. If you look at the epidemiology of neuroendocrine tumors, overall, their incidence has been rising quite rapidly. This is a chart showing the incidence since the 1970s till today. And you will see that while the overall cancer rate in this blue line has remained fairly stable, the detection of neuroendocrine neoplasm has actually increased many-fold in that same period. I think this is actually because of a lot more imaging that we perform, because many of these patients will be found incidentally with these tumors when other imaging is performed. If you look at the incidence trends, overall, the most common site of this disease is still in the lung, and that has been going up over time. But various sites in the gastroenteric system, such as the small intestine, followed by the rectum, and then the pancreas, you can also see that there's been quite an increase in terms of the detection of pancreatic neuroendocrine tumors in this time. Again, I believe this is because of the increasing rate of imaging of the pancreas, especially with multiphasic studies, which allow the identification of much smaller neoplasms within the pancreas. Because of the rising rate of detection incidentally on imaging, you can also see that most of these newly diagnosed neuroendocrine neoplasms are actually detected much earlier. While the rates of all types of neuroendocrine neoplasms has been going up, if you look at this chart, the grade 1 neuroendocrine neoplasms have been increasing rapidly, and most of the neuroendocrine neoplasms we pick up nowadays are actually localized rather than with distant metastases. So over time, the epidemiology has been changing because we have been doing much more imaging for our patients. The World Health Organization groups the classification of these neoplasms into grade 1, 2, and 3 neuroendocrine tumors, depending on the degree of mitosis and reflected in terms of the Ki-67 index. Generally speaking, the higher the Ki-67 index, the higher grade of the tumor, the more rapidly these tumors are dividing and growing. If the tumors are no longer well differentiated, they are actually classified as neuroendocrine carcinomas of either the small cell or large cell type, and they can also be mixed neuroendocrine neoplasms when there is a mixture of different differentiation. If we look at the overall survival, what is the prognosis for patients with neuroendocrine neoplasms, we can see that there's actually a very large difference between a low-grade neuroendocrine neoplasm at grade 1 or grade 2 versus the grade 3 or poorly differentiated tumors. For lower-grade tumors, there's actually very high overall survival. For example, 14 years in a small intestine grade 1 neoplasm, or even 30 years in a grade 1 appendiceal neoplasm. However, for grade 3 or poorly differentiated tumors, there can be a very, very short survival time with overall survival of about 6 months in the lung or 4 months in the colon for these higher grade tumors or more poorly differentiated tumors. So it's actually really, really quite interesting because the low-grade and high-grade tumors behave almost like two entirely separate diseases, with the low-grade tumors actually surviving a long time without treatment, whereas it's very, very important for us to pick up the higher-grade tumors, diagnose them, and get them treated rapidly. So because most of these tumors actually present with very non-specific symptoms, anatomic imaging using CT or MRI is usually performed for initial evaluation. The tumors are very rare and heterogeneous. They can appear, as we can see, both in the thorax as well as various sites in the abdomen. And so functional imaging techniques, which I will be describing later, are only performed when there is a very high suspicion of a neuroendocrine tumor, either on imaging, clinical, biochemistry, or histological grounds. So as for CT or MRI, anatomic imaging for neuroendocrine tumors, the National Comprehensive Cancer Network in the US now recommends CT or MRI for the primary site of disease. This should be multiphasic contrast enhanced, including both arterial as well as portovenous phases, and should definitely cover the liver. The thorax should also be imaged with or without contrast. And so what do we normally see when we see a neuroendocrine neoplasm? I think most people in this room will be familiar with the typical imaging features. Most of these tumors are hypervascular with avid enhancement during the arterial phase. The tumors can be homogeneous, or they can also have cystic or non-enhancing areas. So these are two lesions seen within the pancreas, and you can see that they are arterial enhancing lesions with very avid enhancement, and therefore they stand out over the background pancreatic parenchyma. So this is an interesting case that was shared with me by Dr. Teo Wei Chi from Singapore. So this particular patient on both MR and CT didn't show very much enhancement. In fact, this lesion in the caudate lobe actually shows relative hypodensity on the CT and low signal on the arterial phase MRI. But this actually turned out to be a neuroendocrine tumor, and it was quite interesting because on contrast-enhanced ultrasound, and I'll page through the images here, the lesion actually showed very rapid enhancement and then washout. So it's just interesting because hypervascular tumors, sometimes it depends on the phase in which you image. The arterial phase studies that were done previously were probably done a little bit too late and therefore didn't pick up the very avid and early enhancement followed by washout in this particular tumor. Of course, hypervascular lesions have quite wide differential diagnosis, as you will be aware. Hypervascular metastases, for example, renal cell carcinoma, GS tumors, or even intrapancreatic spleen. All of these lesions can also show hyperenhancement during the arterial phase. Just to show that the image in the bottom left here is one of the ways in which we can differentiate the intrapancreatic spleen or splenunculus using a spleen scan, which can either be done with sulfur colloid or heat-damaged RBCs. Another classical presentation for neuroendocrine tumor in the abdomen is with a metastatic node with a desmoplastic reaction around the node from a small bowel neuroendocrine tumor. A lot of times in these cases, the primary tumor may not be well imaged, but the nodal disease can be quite florid. Of course, in the lung, another classic presentation is that these carcinoid tumors are typically centrally located and endobronchial, which can cause distal obstruction. So what are the other advantages of our spatial and anatomic imaging techniques? So with the high spatial resolution, these studies can be used for both biopsy guidance as well as pre-treatment planning, because surgery still remains the treatment of choice when the tumor is resectable. To assess for resectability, it demands very accurate assessment of local tumor involvement, for example, the vessels, as well as the biliary or pancreatic ducts, as well as invasion of adjacent organs. So when we think about anatomic imaging for the purpose of neuroendocrine tumor evaluation, we know that it is often done as part of the initial evaluation. Because of the high spatial resolution, it can help us in terms of biopsy guidance and assessment of resectability. And one other very useful thing is that the use of ultrasound or MRI can be used to follow up young patients with MEN1 who may require repeat imaging in the course of their lives. Because neuroendocrine tumors are typically very slow growing, especially for the grade 1 and 2 lesions, multiple imagings may need to be done. And interestingly enough, for MEN1, 66% of patients actually die because of associated malignancies. So screening recommendations will include annual radiological and biochemical surveillance, for which MRI or ultrasound may be preferred for the lower radiation risk to these young patients. How about functional imaging? So functioning imaging for neuroendocrine neoplasms actually has multiple different tracers that can be used. The most common and well-known are actually somatostatin analogs, of which there are SPECT tracers such as octreoscan and various PET tracers, out of which the most commonly used today include gallium-68 DOTA-NOC, DOTA-TOC, and DOTA-TATE. For higher grade lesions, FDG, 18F FDG can be performed. And for insulinomas, glucagon-like peptide analogs such as exendin-4 can be used with both SPECT and PET tracers available. For medullary thyroid cancers, fluorine 18F DOPA can be used as well. And as mentioned before, there are various techniques for imaging suspected intrapancreatic spleen, such as sulfur colloid or heat-damaged red blood cells. Today, generally speaking, the SPECT tracers are not commonly performed if the sites have the capability of using PET for imaging. So today, PET tracers, especially somatostatin analogs like DOTA-TATE and DOTA-NOC, are more commonly used to image these tumors. So what are the advantages of using somatostatin receptor imaging in the evaluation of neuroendocrine neoplasms? Before we can use it, we first need to be aware of the normal sites that express somatostatin receptors. So in this imaging example of a normal whole body PET with DOTA-TATE in this case, we can see that the pituitary gland, the salivary glands, the thyroid, especially the spleen, which is quite avid, the liver, adrenals, and in the urinary system, there is quite a fair amount of tracer. But quite importantly, and I will reference this later, there's also variable uptake in the pancreas due to islet cells also expressing somatostatin receptor. This is particularly notable in the head of the pancreas and in the uncinate process, and can lead to issues in diagnosis. This is a case that was being evaluated for a pancreatic neuroendocrine tumor. And you can see in this oblique maximum intensity projection, there's actually a very avid lesion that is seen in the tail of the pancreas, which is the primary neuroendocrine tumor. In this same patient, there was a solitary bony metastasis in the skull. Of course, in this location, it could also be a meningioma, but in this particular patient, it was proven to be a metastasis. So one of the main advantages or strengths of the functional imaging techniques, in particular somatostatin PET, is that we can do whole body imaging with a very high target to background ratio, with very high sensitivity and specificity for evaluating these tumors. How high is the sensitivity and specificity? In a review by all, they found that receptor PET highest sensitivity and specificity of all different modalities, followed closely followed by receptor SPECT, MRI, and actually then FDG PET. Sensitivity in evaluation of neoplasms has been to be in excess of 90%, specificity as well, with a curve of 0.98. Study, we find that gallium-68 detected 95.1% of neoplasms in gastroenteropancreatitis versus only 45% anatomic imaging techniques using SPECT. Picking up these additional results in a change in management in 1/3 of cases. Patients with carcinoid symptoms, biochemical testing was able to detect lesions in 1/3 of cases. These lesions were neither detected by imaging nor SPECT-CT. ENET's consensus guideline of pancreatic neuroendocrine said that PET-CT with somatostatin analogs has the highest sensitivity for localizing PNETs, as well as generally for other neuroendocrine tumors, and also very high specificity. It is the method of choice for staging and locally assessing the local extent of disease in patients with non-insulinoma PNETs, and frequently results in change in management in up to 50% of patients. One particular note is that in the case of insulinoma, somatostatin receptor PET actually has quite low sensitivity of only about 25 to 31% for localizing the primary lesions. Nowadays, we are able to do exendin PET for this particular indication with a very high sensitivity of about 94% for localizing primary lesions, though this is slightly lower in malignant insulinomas. The sensitivity of somatostatin receptor PET is slightly higher in metastatic lesions in insulinoma. This is a particular case from our institution where we were able to localize the primary insulinoma here within the head of the pancreas. So the first strength of using functional imaging is the high diagnostic accuracy, but it can also be used to assess somatostatin receptor status of the tumors. This is important if we are about to treat the patient using peptide receptor radionuclide therapy, as in the NETTER-1 trial, or if we are considering treating the patient with cold somatostatin analogs, which can often slow the progression of the disease, as in the CLARINET trial. Furthermore, there is prognostic value that can be found in imaging the patient using functional techniques. In aggressive disease, we find that FDG avidity increases quite a bit. While in a grade 1 tumor, FDG is only positive in 40% of cases, in a grade 3 tumor, 93% of them actually show FDG avidity. And it is found that increased FDG avidity correlates with poorer survival. In this particular paper, as they assigned the degree of FDG avidity a grade, the lower grade FDG avidity had very high overall survival, while the cumulative survival in grade 2 and grade 3 was significantly lower. At about the 8 to 9 year period, we find that only 20% of the patients with a metabolic grade 3 were surviving, while in a grade 1 degree of FDG avidity, there was almost 100% survival even at that duration. Conversely, as the tumors become more dedifferentiated, they actually show lower uptake on somatostatin receptor PET. It was found that in grade 1 or 2 tumors, a lower uptake within the tumor was associated with a worse prognosis. And so combining both of these pieces of information, a net PET score was proposed back in 2017, where we consider whether the tumor is positive on somatostatin receptor imaging or on FDG or both. In lower grade tumors, they will be assigned a P1. That is when the tumor is positive on somatostatin receptor imaging but negative on FDG. Conversely, if the tumor is negative on somatostatin receptor imaging but positive on FDG, that would be a grade 5. And so we are able to prognosticate tumors by seeing their relative uptake on somatostatin receptor PET and FDG. So on the left, in this particular case, that same patient with dotatate and FDG PET, we can see that the lesions within the liver are hot on the dotatate PET, but they do not show any increased uptake on FDG. This would be a P1 or lower grade tumor. Whereas on the extreme right, we see that within the liver, there's extensive disease on the FDG PET, whereas it shows relatively low uptake on the dotatate PET. So after the proposal back in 2017, this was recently validated, and they looked at the tumors that have a P1, which means high uptake on somatostatin receptor PET, but low uptake on FDG, versus P5, where there is uptake on FDG, but low uptake on somatostatin receptor. And we can see the green curve here on both the overall survival as well as progression-free survival shows a significant difference between the P1 and the P5 cases, proving the prognostic value of dotapeptide PET combined with FDG PET in these patients. I, however, have one caveat. These are two cases from my department that were imaged back in 2005. The arrows point to focal uptake on dotapeptide PET within the pancreas. One of these patients actually has a neuroendocrine tumor, but one of these patients was normal. So in the top case, it was actually a false positive, intensely avid, but when we recommended for evaluation, the patient underwent surgical exploration, but there was nothing there. There was no tumor found on surgical exploration. The patient remained stable for 7 years and was well even up to 11 years later. However, the case on the bottom was a true positive. This was a slightly lower avidity lesion, actually, with a 1 cm hypodense lesion seen on the corresponding CT. And when the tumor, which was removed from the body of the pancreas, was examined, it was found to be a well-differentiated PNET on histology. So this brings me to one of the biggest and most important limitations we have to remember for somatostatin receptor PET. Earlier on, I told you about the high sensitivity and specificity of this mode of imaging. However, if we look at a subdivision in this other study, looking specifically at pancreatic neuroendocrine tumors, we will find that in the diagnosis and staging category of imaging for patients with pancreatic neuroendocrine tumors, the specificity of PET alone is actually fairly low, only about 50%. In non-insulinoma, it is about 57% when they did a sub-analysis, and only about 30% in insulinoma. This is one of the biggest limitations that we have for somatostatin receptor PET. It is sensitive and specific in extrapancreatic sites, but within the pancreas, as mentioned, because of the high expression of somatostatin receptors, it is very, very important before we recommend any sort of intervention that the finding is actually verified on either CT or MR. We need to see a focal lesion on CT or MR before we can say that there is a tumor there. Otherwise, it may simply be hypertrophy of the islet cells, but no true lesion is present. And so we can see that the role of anatomic imaging in the evaluation of neuroendocrine tumors is not only just for initial evaluation for the high resolution before treatment and in planning of biopsy, as well as minimizing radiation exposure, but workup of false positive results due to physiological uptake or inflammation. This is particularly so in the pancreatic uncinate process, but can also be seen in other sites, post-surgery, infection, or inflammatory causes. So in conclusion, I would like to just bring your attention to a few details about both functional and anatomic imaging. Functional imaging in neuroendocrine tumors has a very high diagnostic accuracy, in particular with the use of somatostatin receptor PET. It can also be used to assess somatostatin receptor status, prior to treatment with somatostatin analogs as well as peptide receptor radionuclide therapy. Combined with FDG, we are able to have prognostic value when we see whether the lesion is avid on somatostatin receptor, PET, or FDG. Anatomic imaging, of course, remains key in initial evaluation, in guiding biopsy and resectability, in workup of false positive results, as well as to minimize radiation exposure in patients who may need multiple repeat imaging over time. So, in conclusion, receptor PET points to stage patients with known or but we should remember the essential MR in initial evaluation and diagnosis. And only the integration of both our functional and anatomic techniques will allow for optimal patient assessment and treatment. So I'd like to thank you for your time and attention and invite you to join us next year for the Asian Oceanic Congress of Radiology, which will be held in Singapore from 20th to 23rd August. Thank you very much for your time.